Hey, future respiratory therapists. So a question here comes from David, and she's always messing with me, guys. I got my wife back here in the background, always messing with me, making funny faces, and I just love her.
Oh, you get to send your video?
Anyways, here we go. We're talking about Airvo today. And what we're talking about specifically is what are the benefits of it? How do I know when to use it? Is it appropriate for a patient that's hypercapnic? And when do I choose Airvo over BiPAP or CPAP? And so that's the question. It comes from David. I appreciate you sending me this question. And here we go. So we're going to break down the benefits of Airvo. Now there's 4 major benefits to the Airvo system, which is a heated, high-flow nasal cannula system. It can deliver flows up to 60 liters per minute and can deliver FiO2s up to 100%, which makes this an extremely valuable tool. Now I'm going to tell you, I'll give my bias out right up front. I am an Airvo lover. Like, I think this is potentially one of the greatest devices to come into the world of respiratory therapy since I've been in it. So we're talking almost 20 years in the field, and we've seen EasyPAP and AccuPAP, and we've seen the declination of IPVB and the rise of Metaneb. And we've seen the introduction to new vent modes such as APRV and bilevel and those things. And they're all great, and I love them all. But Airvo is one of my favorite devices. Not because I think it's cool, but because I think it is truly one of the most beneficial devices for our patients. So let's talk about it. Like I said, there's 4 benefits. So I'm going to break those down, and I'm going to go through and answer the rest of your questions, David, that you sent me, okay? So when we talk about Airvo, here we go. The first benefit is that we get an increased level of oxygenation. Now, this comes from 2 factors involved with Airvo, okay? So when we think about Airvo, we have a fixed FiO2, which means we can tell the device how much FiO2 to give. And that's good. It makes it a high-flow device. Remember, a high-flow device, a high-flow oxygen device, just like a Venturi mask, says that we're going to meet or exceed the patient's inspiratory flow, and we're going to deliver a fixed FiO2, which means you can deliver low FiO2s at high flows. You can deliver high FiO2s at high flows. And this device is probably the number 1 on the market, in my opinion, at being able to deliver an FiO2 of 60, 70, 80, 90, even 100% if you needed it at a high level of flow. All right. Now, the other way we deliver increased oxygenation is through the administration of PEEP. Now, this is controversial because it's not a closed system. If you're familiar with the Airvo, the high-flow nasal cannula, you know that it's 2 prongs that fit inside the nose. Now, what they say is that when you're using the proper size cannula, which means you look at your patient's nares, you choose the appropriate size. The appropriate size should be approximately 50% of the patient's nares. So if you have a patient with really big nares and you choose a small nasal cannula, you're probably not going to get the same PEEP effect that you would if you chose the medium or the large nasal cannula, depending on the size of the nares. Now, typically, I just look at this and go, they got really big nares, I go with a large. If it's like on the fence, I go with a medium. If they got small nares, I go with a small. What they say about the PEEP is that anything above 40 liters per minute generates about 1 centimeter of PEEP for every 10 liters of flow. So what they're saying is that at 40 liters per minute, you're going to be able to generate about 4 centimeters of water pressure. When you get to 50 liters per minute, you're looking at about 5 centimeters of water pressure. 60 liters per minute, about 6 centimeters of water pressure of PEEP. Now, this changes if your patient is sitting there and breathing with their mouth wide open. Then obviously the PEEP factor is going to diminish. So it gets complicated here because you say, okay, how does this generate PEEP? Well, first of all, the flows are so high that it creates an expiratory resistance that stents open airways and alveoli and creates a PEEP. So that's the first level. The other level is if your mouth is closed, then that PEEP effect is even greater. If your mouth is open, then obviously you lose some of that PEEP effect. Okay, so it's not perfect. It's not like it's not like CPAP where you strap this tight mask on their face and you generate 5 centimeters of water pressure. So it's not the same in that arena, but it does show a level of effective PEEP when you choose the correct nasal cannula size, and even more so if the patient is breathing through the device with their mouth closed. Okay, so PEEP and FiO2, 2 things that help to increase our arterial oxygenation. So obviously that right there tells you that this is a good device for somebody who does not have a ventilation problem, meaning they are effectively removing CO2, yet they're not effectively oxygenating. So this device would be perfect for that patient because you can deliver an increased oxygenation through a set flow based off of how the patient presents and a set FiO2. Now, the next thing we talk about is decreased dead space. Now, decreasing dead space is a result of the high flow. So, as the patient is breathing, you're getting this constant flow of gas into the upper airway. And this gas that's coming in is FiO2 enriched, which means if you're set on 50%, then you're getting this constant flushing of the oropharynx, the nasopharynx, the larynx. You're getting this massive washout of exhaled dead space, which is mostly related to anatomical dead space. So you have your upper airway, you have your oropharynx, you have your nasopharynx. All of that at the end of exhalation is still filled with CO2 enriched gas. Now, with the Airvo on, you're getting a constant flushing out of that anatomical dead space gas, which is going to improve your alveolar tidal volume, which means the next breath they take is going to be more effective in the first portion of it. Instead of it being rebreathed gas from our oro and nasal pharynx, now, since that's washed out and filled with this gas from the high flows and the fixed FiO2s, now you get a more effective tidal volume, which will aid in better gas exchange, better oxygenation, better CO2 removal. If you can decrease dead space at any time, then you're going to improve alveolar tidal volume and improve gas exchange. So remember that, because we're going to come back and talk about that here in just a second. Now, the third thing here is when we talk about an increase in heat and humidity. Now, I believe that Airvo is probably the best device on the market right now that is capable of providing adequate heat and humidity to the airways. Now, why is this important? Because heat and humidity, adequate heat and humidity, equates to better mucociliary transport, which means the cilia are going to respond better. They're going to remove and move out secretions better. You're going to have better humidification of secretions that have a tendency of drying out and becoming stagnant with other devices. But with this device, you see that opposite. You see the cilia beat is improved. You see the mucociliary escalator works more effectively, and you see an improvement in secretion clearance. because it's just easier because of the adequate heat and humidity that's applied to the airway. Now, the fourth point is patient comfort. Any patient that I've seen tolerates an Airvo much better than they tolerate a BiPAP or a non-invasive CPAP, such as, a mask strapped onto the face, connected to a non-invasive ventilator, and providing inspiratory effort assistance through BiPAP with IPAP, and then expiratory positive area pressure being EPAP or CPAP with the BiPAP or the CPAP. Nobody wants a mask strapped to their face to aid them in breathing. So this device actually removes that and leads to greater patient comfort, which leads to better patient compliance with the device. Those are the 4 components of Airvo that are beneficial to your patient. Okay, now your question was how do I know when to use it? And the answer to that question is I look at it like this. If I have any patient that I am concerned about, that I look at them and I go, I just don't really know if this patient is going to continue to deteriorate or if they're going to get better. If they're on the fence, I err on the side of the reduction of escalation of care, and I go to an Airvo. I put a patient on an Airvo. I give them a fixed FiO2. And look, now I'm not saying that I look at a patient and go, oh my gosh, they need 80%. I'm not saying that. This patient can be on a nasal cannula at 3 liters, right? Which is approximately 32% FiO2. It's not fixed. It's variable, but it's approximately 32%. When I look at that patient, I say, I don't really like the way you look right now. I don't know if I'm going to have to come in here an hour from now and increase you from 3 liters to 4 liters, or maybe 3 liters to 5 liters, and eventually go to a venti mask, and eventually go to a non-rebreather, and eventually go, are we going to intubate, or what are we going to do? You may try BiPAP? What do you may do? I don't wait till that point. I see a patient who is on the fence from a work of breathing perspective, from an oxygenation perspective, those 2 big ones, and I go, you know what? Let's put this patient on an Airvo. I deliver 32% FiO2 at a flow of 40 or 50 liters per minute with adequate heat and humidity and adequate patient comfort, and I reduce the escalation of care. So any patient that you think is on the fence, you should think maybe we need to go to an Airvo. Let's get ahead of the game instead of chasing the game. Here's the whole deal, guys. For most of my career, respiratory therapists have chased the game. We've never been really, really good at getting ahead of the game and being proactive instead of reactive. Airvo brings in a game changer that allows us to get proactive. It allows us to say, you know what? This person's secretion clearance is questionable. Their oxygenation is questionable. Their work of breathing is questionable. Let's fix it. Let's attack all 3 of those right now with one device, Airvo. Put them on it. And see what happens. See if they don't go from being questionable to going, I feel good about this patient now. So that's what I'm going to say to you about that. When do you use it? Anytime you think you should. Anytime. You got a COPDer who's on a 2-liter cannula, but they're flow hungry? Put them on an Airvo. 28%, 50 liters per minute. Watch what happens. Guarantee you'll have better results. Okay. Now the last thing, excuse me. The last thing that you asked me was how about the hypercapnic patient? This is a patient that presents with a high CO2. When do I know? When is Airvo a better option than BiPAP or CPAP? And the answer is that Airvo is not always the answer. If you have a patient who's struggling to maintain an adequate tidal volume, you can see that they're not able to generate an adequate tidal volume, you probably need to go to BiPAP. you probably need to initiate non-invasive BiPAP, give them a little bit of pressure support, the difference between IPAP and EPAP, and help them generate a greater tidal volume to keep them from being mechanically ventilated. That's just the bottom line. But if you have a patient that just presents with an increased work of breathing, they may be slightly hypercapnic, but they're taking good tidal volumes, and you look at them and you go, you know what, guys, let's try an Airvo. You don't even really know unless you try. You're like, I don't know if BiPAP is quite right yet. There's no numbers to support this, okay? You can't, I wish I could tell you, like, if you draw an ABG and the CO2 is this, then you go to BiPAP. If it's less than this, you go to Airvo. If it's less than this, you just go nasal cannula. I can't give you that information because it's not out there. What you have to do is look at each individual patient. You have to assess them. How do they look? What is their spontaneous tidal volume look like? If they need help with that, they probably need a BiPAP. If they have an increased work of breathing, but you look at them and they have good chest excursion, like they're getting a good tidal volume, then let me tell you, Airvo, by reducing dead space ventilation, can 100% help a hypercapnic patient and keep them from being reintubated. Now, I'm going to get lots of flack on this. I know I am, because you're going to go, oh, it doesn't do anything to tidal volume minute ventilation. That's a lie. If you decrease anatomical dead space, then you increase anatomical tidal volume. You increase alveolar tidal volume. And if you increase alveolar tidal volume, then you increase alveolar minute volume. And that results in a greater removal of CO2. So 100%, you can take your patient that is hypercapnic. If they're in acute vent failure, you got to consider, are we going to try to keep them off the vent, put them on BiPAP, or intubate them? But if they're not to that stage yet, and you go, I want to try something that maybe can help this patient and their work of breathing, they're going to be more compliant with it because it's a greater level of patient comfort, because it's not a mask strapped on their face. It's just a nasal cannula in their air, in their nose. Then try it. What's it going to hurt? The patient's probably heading towards intubation anyways, right? Try it for 30 or 45 minutes. If it doesn't work, then go to BiPAP. And if that doesn't work, then intubate them. But you got to understand that this tool, through the decreasing of anatomical dead space, can 100% remove and lead to the removal of better gas exchange and better ventilation, which will remove more CO2. Okay? That's my answer for you, David. If that's what it comes down to, man. You got to take each and every patient. Let me tell you when I use Airvo the most. When we have a patient coming off a ventilator and it's questionable, like everything looks kind of good, but it's questionable of if they're going to really be okay or if they're not. Like, are they really going to fly or are they not? Are they going to be reintubated? Is this going to be a successful or a failed extubation? I always err on the proactive side, and I say, let's extubate the Airvo. Let's do it. And watch what happens. Airvo has a very, 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 very low reintubation rate because of these 4 factors. So ask yourself, let's extubate the Airvo. Now, here's what you're going to get. Nah, we're not going to Airvo. Well, why aren't we going to Airvo? Because we only have 6 of them, and I'm not going to use it on this patient. Not a reason not to go to Airvo. Because you only have 6, you got to increase the need for the device to turn that fleet of 6 into a fleet of 40. So that everybody who is questionable and on the fence for extubation and on the fence for intubation at least has a chance to avoid intubation or a chance to be extubated. That's the name of the game, guys. Don't let equipment restraints drive your decision making. Because if that's the case, then very few people will be on Airvo. You got to make the need to get more. And you do that by showing outcomes that support fewer vent days, equal fewer ICU days, equal fewer hospital stays. and fewer hospital days total. That comes through what this device offers. I'm no way, any shape or form related to the Fisher-Paykel Airvo device. No way. No monetary fees coming towards me. I get nothing off of telling you this information. What I get is the satisfaction of you providing better care to your patients. And that's it. If we can keep 10 people off the vent tomorrow because we utilize this device, fantastic. If we can get 10 people off the vent tomorrow because we extubate to Airvo and they stay off, then fantastic. We're doing our job as respiratory therapists. Hey guys, go be great.